So, moving down the line, we have dealt with folic acid, we have dealt with topoisomerases, and now we are moving into transcription. So, is there an antibiotic that interrupts transcription? The answer is yes. And if you recall, let's say we've got that kid who has, a grandparent with a chronic cough that comes to help out, and and the kid starts developing, poor weight gain, low-grade fevers, cough, that kind of thing. What do we have to worry about? Well, we have to worry about TB. And what do we put most people with TB on? RIPE therapy. And what does RIPE stand for? It stands for rifampin, INH, pyrazinamide, and ethambutol. And one out of the four of these involves the inhibition of transcription. And which one is it? It is rifampin, if you guessed it correctly. All right, so let's be fun. And I'll give you one of the side effects for free by selecting this color. So let's talk about the rifamycins. And remember, since I'm gonna break these into lectures, we're just gonna recall the things we have to remember. It's edutainment, so remember you still need to verify all information and make sure that you're using multiple sources and always consult your antibiogram because that is much more important than anything I say here. All right, so rifamycin. So there's a bunch. I will tell you but the one that I think we'll just mostly talk about is rifampin. That being said, there is rifapentine and rifabutin and several others, but the one other one we'll mention briefly is sort of a more new one called rifaximin. I think it's rifaximin. Rifaximin. Double check, so I'm not lying to you. Rifaximin, yeah, IMIN. Rifaximin. Okay. So, rifampin, what does it work on? So recall, we're going to again go through this list of things, and every time, just to remember that as simple as it would be to say, oh, gram positive, gram negatives, there's nuance there. Remember, levofloxacin had good MSSA, but not great MRSA coverage. There's just these nuances, and there's no way around them, and you just kind of have to know them and refer back or look at a guide to help you. But I think it's helpful to just at least be exposed to it once in a lecture format. So here we are. Rifampin. Let's have a look. Does it work on MSSA? The answer is yes. Does it work on MRSA? Can we use it to treat certain MRSA infections? The answer is yes. All right. Do we have coverage of group A strep? It does work on group A strep. Works on all these guys too. Does it work on viridins? It does. Does it work on pneumococcus? It does. In fact, if there's drug-resistant pneumococcus, we might actually, especially in a meningitis, we might actually think about adding rifampin. It gets into the blood-brain barrier, past the blood-brain barrier very well. Working fecalis, yes. Feces, I'm a little more careful, but it might. In many cases, does it work on E. coli? It does. Clab, yes. Proteus, oh my gosh, it works on all these guys. Pseudomonas, there's actually certain articles showing some synergistic activity on Pseudomonas. Steno, yep. Neisseria, we'll actually talk about a specific use of rifampin in that case. Gonococcus, Haemophilus, yep. So work on atypicals. It has excellent atypical coverage. Yep. In fact, interestingly, in serious intracellular pathogens, you might actually want to consider additional rifampin because, again, it gets intracellularly very well as well. Works on anaerobes. It sure does. So work on BFRAG. Does, of course, we use it in TB as long as it's not drug-resistant TB. Does it work in at least many NTMs? Not all, but certainly many NTMs. Oh my God. Rifampin is amazing. Why don't we use this? It works on everything. Pick on the poor ER doc again. Why isn't he out there or she out there prescribing rifampin to everybody? I mean, if levofloxacin was a one-stop shop, rifampin is even better, right? It treats everything. Uh, and I usually give you a minute to pause and think about why no one is using rifampin for absolutely everything. And so most people will say, okay, well, it's side effects, right? It's got to be really bad. So let's just start with the side effects and then we'll move on from here. So what are the big toxicities with rifampin, or the rifampin especially? Well, one I've hinted at with the color, and that is orange. And you're like, a side effect is orange? And the answer is yes, the side effect is orange. Rifampin, if you ever see it being hung like via IV, it looks like orange, like bright orange Gatorade going into someone's veins. It gets into all the tissues, and everything. So tears will turn orange, the CSF will turn orange, like you can see in a patient with with an externalized shunt, for example, that their CSF will have an orange tinge. Urine will turn bright orange. Stool can even look a little bit orangey in the water, and any bodily fluid, we'll just stop there, can turn orange. So orange is side. Is it dangerous? No, it's not deadly to be orange. I'll save any political jokes. What is another big toxicity besides orange? The biggest thing that we will have, and I'll give you a brief example. Let's say, unfortunately, the child who grandma's coming to help, who unfortunately is going to give that child TB, let's say they have a seizure disorder, and are chronically ill and have a seizure disorder, and all of a sudden you start them on right because you're like, okay, this child has TB, and they start seizing, and you're like, well, why did this kid just start seizing? And sometimes people will answer, well, maybe it has some neurotoxicity. It doesn't really. Its biggest issue is, what else is that child on? They're probably on anti-epileptic drugs, and rifampin increases or decreases the CYP450 system. So recall we have the CYP450 system, and that's involved in metabolizing a lot of drugs. So if the child is starting to seize after you put them on rifampin, did it increase or decrease? Think about that for a second, and why? And the answer is, it induces CYP450. It's a CYP450 inducer. And what does that mean? Well, if it's increasing the enzyme that's destroying things, then you're going to cause decrease levels of your drugs that are metabolized by that CYP450 system. And so there's plenty of not all drugs, and there's specific CYP450s that are involved, and I'm not going to get into all the details. Those are things you should look up. Always do an interaction meter, but most importantly is that you recall is that rifampin can interfere with the metabolism. That's actually why in sort of I think the general public, when they say like, oh, you can't, drink with antibiotics, and you can't take, you have to be really careful about birth control and antibiotics. Well, that's true for rifampin. In fact, rifampin is the reason that we worry, especially that and the azoles would be the two big ones that mess with the CYP metabolism. But something like cefazolin, amoxicillin is not going to affect alcohol metabolism. It's not going to affect hormone hormone replacement therapy or birth control, hormonal birth control methods. And so it's really rifampin that is the interaction that I think most people when they commonly think of like, oh, I can't be on these things, it's because of this. But that's it. Those are the big toxicity. Another one that can sometimes pop up is hepatotoxicity. I will say, of the ripe therapy, INH, maybe pyrazinamide to some degree, are the two bigger offenders, rifampin being much less likely to cause serious hepatotoxicity. It can, but it's not the most common. Okay, so are any of these reasons? I mean, sure, if the person you're treating in the ER is on other medications, then this might become a deal breaker. But the majority of people are just coming in with an illness. They're not going to necessarily be on any medications where this interacts. So rare hepatotoxicity and orange are not generally a reason a physician would avoid it. So why not? Again, why not use rifampin for everything? It's not toxicities. And the answer is resistance. So, but I just told you that everything is susceptible. So how can resistance be the reason that you don't use it? And this gets down to microbial evolution. So it turns out that the way it binds into the RNA, the the transcriptase has a binding pocket, where it's feeding the DNA through and spitting out the RNA strand, and which is encoded by importantly an 80 base pair region. Although there's certainly, many other nucleotides. This is not just a tiny protein, but in this 80 base pair region, all you need is a few like a one amino acid substitution, which can be based on a single nucleotide polymorphism, also known as a SNP, which you might have heard of. And boom, suddenly you've excluded rifampin. And remember that when you have an infection, you don't just have one bacteria. You have thousands, hundreds of thousands, millions, billions even of bacteria. And what's the likelihood that at the default state, some or many of those bacteria have single nucleotide polymorphisms in this region? Not to mention the fact that you're stressing the bacteria, and one of the bacterial's response to stress by inducing it is to induce genetic mutation. That's how it evolves so rapidly. And so you will rapidly develop resistance. Oh my goodness, why does that keep happening? Um, um, so you will rapidly develop resistance. And so if you try and treat a course, a bacterial infection with a course of antibiotics, normally the way resistance works in bacteria is you have a reservoir in your skin, in your gut, in your mouth of all these bacteria, and when you expose them to antibiotics, only some of them, especially in your tissues, are getting to the point where they're all dying and you've got your immune system kind of mopping up the remainder. So those are not the ones that develop resistance. What it is the reservoir bacteria in your gut and stuff, which do not get fully wiped out. You have your appendix, you have all these rugae and things that are sort of hiding out where the bacteria are hiding out, and they'll repopulate as soon as your antibiotics stop. And those are the ones that are being exposed to sub-therapeutic levels of antibiotics, where they start to learn and develop resistance and then trade their information. So it's not usually like that first course for instance, like let's say you have a UTI and you're on Keflex, you're going to treat that UTI just fine and you're going to get rid of it for the most part, and there are rare exceptions. It's the next time where you're now harboring these bacteria and one of those E. coli gets into your urinary tract and causes an infection, that you now see the resistance formed, or it's formed on a biofilm, and that one bacteria under there has learned to develop resistance and then comes back. But with rifampin, you can be, a day into therapy, 2 days into therapy, and already start getting relapse. And that's where you just can't use rifampin all by itself. Asterisk, because there'll be an exception to that. But it is the rapid developer resistance. So we always with an asterisk, use it in combination. And where do we use in combination? Well, remember staph infections, maybe even strep infections of hardware. Like if you have a hardware infection, we think of rifampin as getting under the biofilm. The evidence has always been a little bit shaky in terms of how effective rifampin truly is without actually just taking out the hardware and that kind of thing. But we will use it adjunctively in prosthetic joint infections, occasionally in prosthetic valve infections as well. Um, Again, you might see it in combination in drug-resistant pneumococcal meningitis. There is a use case for that. And of course, like I said, in combination in certain serious rickettsial infections, it's a consideration. And you might see it, of course, in combination, and of course, you'll see it in combination for treatment of TB. So that's its general use cases. When I said the asterisk, that's because there are, in fact, two cases where we can use it all by itself, and that is in not treatment, but prophylactic exposure to meningococcus, and one of which I kind of left under Haemophilus, but Hib. So if you have like an unvaccinated SIB who was exposed to Hib, you could use it there. Or if you were on a long plane flight, or your dorm roommate got infected with meningococcus, you would be given rifampin. And a single, 2 doses of rifampin. Remember, it gets on mucosal; it's bactericidal, so it has all the things. And remember, the inoculum is going to be low enough that you generally don't have to worry about it suddenly developing resistance, because there's only a couple bacteria that have transmitted to you that will slowly and steadily grow and cause problems. But at least until the infection is actually developed, it's a very reasonable prophylaxis for those 2 infections. So that's where you might also see. All right, great. This is why I worry about rifaximin, because the way rifaximin is used, it's used in treatment of, for instance, it's labeled for use of C. diff. It's used in gut overgrowth, like patients who have SIBO. People will use it in motility and those kinds of things. And I just worry, because of the mechanism resistance, I just don't see how long it would truly be effective. But again, that is my little spiel about my concern with rifaximin. All right, let us keep moving on this train.